okay? Little old ladies, because their back started to deteriorate. You could get sometimes a picture where their lungs are down by their hips, right? It's just how they're built. So you can collimate. You take a look at the patient, okay? On smaller patients, you need to bring it in so there's about 1 inch shadow on the side. And of course, do your exposure at the end of expiration. Some things that we're looking for. We're looking for the size and shape of the liver. We're looking for the spleen. If there's any swelling in the spleen. We're looking at the kidneys. We're looking at the intra-abdominal calcifications and any evidence of a tumor. So, this is a pretty decent upright abdomen. I say decent because what are we missing?
Markers.
The markers. Okay, but these arrows are pointing at air fluid levels. See how the air doesn't look fluffy, it looks blunted, right? It goes like that, okay? So they've got a lot of air in their bowels. This patient might have an obstruction, okay? So I'm gonna point this out. Marker indication, upright position. Now, I know you guys have to get markers. Christy, you got markers with little BBs in it, right? We used them yesterday in lab. That's great because some facilities want to see those BBs, because if the patient is truly upright and it's right here, the BBs should be laying down in the bottom half of that little circle, okay? If the patient is flat and you put the marker on there, then the BBs will be in the center of the circle, okay? So, if you just have a regular marker, left, right with your initials, perfect, put that on there and then label it upright, okay? That's where you want to use that electronic labeling, okay? It just helps the radiologist. So you want to see evidence that you're collimating. It's similar criteria as the supine position, but you don't want to see any motion with that diaphragm. And your brightness or the contrast, how much grays you have in the picture, it needs to be similar to supine, okay? And again, I can't stress enough, make sure your marker shows up. Some of you might be wondering, so where would I put my marker on patient Kendall, right? Some of you thinking that already? Okay, there's a couple different ways to do it. I personally have never had luck with it actually showing up when I put it on the grid, okay, or the IR. I put it on the patient and I put it up high in the top corners of the light, right, where she had light on her armpits. I put my marker up here. I don't put it this way, I put it this way, okay? But you'll find what works best for you. Yes, Kendall?
For the SID on an abdomen, is it 40 inches or 72?
So, if we back up, it's either 40 or 48, okay? 72 is generally for chest x-rays, and then when we get to it, some lateral spine projections.
Sorry, you said what was the SID?
40.
40, okay.
There's your beautiful upright abdomen. What do you see at the top of the image? The diaphragm, very good. Still see the crest and all the soft tissue. Sure. Thank you, Miriam. I'm going to point something else out while we're at it. Diaphragm. Diaphragm. What are these?
The costa angles.
Okay. So this doesn't have a marker on it. What side is this?
Left.
So this is the,
Looks like the right side.
but it's the left. Because this is an AP, it's telling us this is
It's left. It looks like it's shorter than the one on the.
What's this?
Just the liver.
Right. So you know that's the patient's,
Right.
okay. Landmarks, right? Unless this patient has situs inversus, but we're not even gonna go there. So what is this right here, guys?
That is the pleural line.
What's this?
The lungs.
Oh, right.
Right, costophrenic angle, very good, okay. Don't, take a deep breath. All right, PA abdomen upright. I don't think I've ever done this. All right, still an upright projection. The difference with this is that it reduces the gonadal dose when you're not worried about the kidneys, okay, as your primary interest. It's gonna make your kidneys look different. Why?
Because they're farther away from the IR.
Very good. Did everybody hear Lisa? On a PA projection, the kidneys are farther away from the IR. Why? Where are your kidneys? They're towards your back, right? Anybody else love boxing as much as I do? You do, Nicole?
I'm rowdy.
Everybody know about kidney punch, right? Okay. That's why you can get your guy, your opponent back here on the flank and hit the kidneys. You can make their kidneys start to bleed if you hit them hard enough, right? So your kidneys lie more posterior in your body, okay? Which means that they're gonna be, when you're facing this way, here's the IR, you're facing this way, your kidneys are farther back, okay? So, the anterior surface of the patient is at the vertical upright grid. The weight is equally distributed. See the similarities between the AP guys here. Centering is still the same, 2 inches above the iliac crest. And again, this just reduces gonadal dose, and if we're not really concerned about the kidneys. The CR is still perpendicular to that IR, you're still at a 90-degree angle. And it enters the patient at the MSP, so what are you gonna feel for instead of the sternum in this case?
Just
You're
the
gonna, to
vertebrae.
make sure you're centered,
The vertebrae.
yes, you're gonna feel for the spine, right? And then you're gonna feel for the crest to make sure you're 2 inches above it, okay? Again, you don't wanna keep it any bigger than 14 by 17. For smaller patients, you can collimate down on the sides to about 1 inch. And again, guess how you're breathing that patient?
Expiration.
Expiration. Okay. And the evaluation criteria are exactly the same as the AP, upright. A lateral decube. This is one of your competencies for abdomen. So star this, heart this, whatever you need to do. Something we'll start working on in lab next week. It's performed for patients who are too ill to stand. Okay, so this takes place of the upright. The patient's in a lateral recumbent on their right or left side. Left mostly performed unless contraindicated. The left is normally performed, okay? The part position, the patient's laying on the table on a radiolucent sponge. This helps to prop them up. Knees above the level of the diaphragm, so grandma can't bring her arms above her head, but she can do this, that's pretty good, right? You should still get the diaphragm without her elbows in it. Yes, ma'am.
So like I would always some larger patients, how would you do
Good.
meet with them, would they need that?
They may not need that, yes, that is a good question. But you get a lot of extra help. Yeah. Is the best answer I have for that right now. And what she asked is for a very large patient, like morbidly obese patient, you may not need to prop them up because their soft tissue is gonna do that for them, okay? So keeping them on their side is just the same challenge as you have for the decube chest, right? So that's where we flex the knees, right? Give them a little extra support. You center iliac crest to the IR 2 inches above, See the similarities here again, guys? And that's if you want to look for the diaphragm, which most of the time they're still looking for the diaphragm because this takes the place of what?
Upright.
The upright. Okay. No jinxies in this class. My kids do that to me all the time. Okay, so again, the patient's on their left or right side lying down. Flex those knees to increase the stability and comfort. Bring the elbows up. In the next slide, it'll show that the guy's got his arms all the way up, but work with your patient if they're just not able to do so. And the IR is centered again at the level of the iliac crest, 2 inches above. Okay, I wish I could demonstrate this in this room, but I'm not gonna mess with that tube anymore. So you see how the CR is perpendicular to the IR? You can do this on a cart. We do this a lot for tube injections, like if somebody's got a feeding tube. We do this a lot in the ER, where we roll them. And again, 2 inches above the crest, guys, and at the end of expiration, the breathing. So this is very similar to that chest cube that we've been working on in lab. You just go further down the body, okay? Some structures that we're looking for. We're looking for, guess what?
Same structure.
Same thing. And we're looking for free air and fluid, just like we did in chest. Again, you want to see the diaphragm without motion. Both sides of the abdomen, right? Side down when fluid is suspected. Side up when air is suspected. We need to see the abdominal wall, flank structures, and the diaphragm. So let me pinpoint some of those out here. So if this patient could stand, this little air bubble, everybody see this? Would be up underneath the diaphragm, but they can't, okay? So there's some surgical clips, which means this may be recent, and that's why they're suspecting that they've got free air after having some kind of abdominal surgery. You're still seeing the crest, right? There's no soft tissue that we're cutting off here. We're getting real close to this diaphragm, but you can see it, right? And the right side is up. So we've got a nice label marker, okay? And you can see the sponge right here. See this? So those are some of the things that you need to include in your image. So you need to show that you're collimating, that there's no motion. Both sides of the abdomen. You need to see the abdominal wall and all the flank and the diaphragm. Repeat. You don't want to see any rotation, right? Just like the chest. We're gonna look at some structures to make sure there's no rotation. What do you think we're gonna look at on an abdomen like this, in the decute position, to make sure there's no rotation?
The ischial spine. The ischial spine.
Right, so the hips, right? What'd you say, Bailey?
The spine.
The spine starts to look different when it's rotated. The ribs, because you should see a few ribs in here, start to look rotated and different. Appropriate brightness and contrast, same thing, just like the supine and the upright. You want there to be some different grays and different levels of contrast in your image. You don't want it to be too burned out or too white. And again, you want to mark what side is up so there's no confusion, right? So what do you guys think? Is this a pretty good one?
No, that looks terrible to me.
Thank you for your honesty.
You're so welcome. It looks like BS.
I mean,
Just because you're
this-
not used to looking at it.
No, it's fine.
Like I
The
can
spine
see it.
is centered and the diaphragm is pretty much
So
in
you
it.
can't see the spine it looks a little white in the center, right?
Yeah.
Like I can see a spine.
You can see a spine, yeah. This is also projected, so this is a horrible way to show this. If you were looking at a good computer screen with this actual image up, it might look a little different. Just point of reference, guys. But you're gonna look to see if this, like, does one look flatter than the other? Does one look rotated on the
Yeah.
wings of the hips? I can see a little rotation in the spine, just a little, but I'm looking for a Scotty dog. You guys aren't there yet. So this is a pretty good one, but I would say that maybe they needed to change their technique because it looks a little white through the center. Because I can't see that spine clear as.
So
Yes.
when it is super white, does that mean like with technique, would you have to lower KVP?
Yes.
Okay.
Yeah. And you might need to change your mask.
So since there's more, I mean, I know there are still more like dense organs than, but like, you know, then bones are more dense than the like liver
Right.
and stuff, so if it's, less dense matter, like, does that when you like lower your
So like if this
KVP?
patient was really super distended and they had a lot of air in there, that's gonna change how their abdomen looks, right? Versus say contrast or poo, right? Because air is lighter than poo or contrast. So you have to take those things into consideration. If you get a patient that walks in like Kendall, body shape, but she's out to here, like she's 9 months pregnant, you're gonna be like, holy cow, that lady's got some air in her belly, or either she is pregnant, okay? So what are you gonna ask too? Quick reminder,
When was your last period?
when was your last period, right? Any chance you could be pregnant, okay? Especially if Kendall's our patient in this scenario, okay? But going back to what you were asking, so things like that, you have to kind of start to look at pathology and what's going on with the patient to understand what kind of technique you're gonna need.
Like how much KVP and mass,
Yeah.
okay.
Yeah.
I was just saying, because like, when I was looking in the book, like, there
In
was,
this book,
yeah,
Okay.
talking about KVPs, like,
right, every
the
chapter has
chest
that chart, right?
and, yeah, like, I'm just trying to get the association in my head of like, how the KVP affects like certain anatomy in the body.
Well, that's Sarah's class. Is that, cause it penetrates different, right? We're not gonna get off on that.
Oh, well then.
Okay, lateral abdomen. I can, again, count on one hand how many times I've done a lateral abdomen. Guess what it was looking for?
Air, fluid, air,
For all my female patients in the room,
Foreign object. Foreign object?
we were looking for a foreign object that a medical professional had put up in that patient. IUD.
Oh, yeah.
IUD had migrated out of the uterus and was somewhere else. Yeah. Not to scare y'all, but just saying. So that's why I've done a lateral abdomen. You don't do these very often. This is not one of the test outs. Okay? So, a recumbent, it's gonna be recumbent right or left. Again, just like the decube, guys. You're gonna flex the knees, make sure they're comfortable, make sure they're truly lateral, okay? There may be some challenges to this, especially if the patient has a large belly, kind of tends to gravitate the patient down, right? The change in weight. Bring the elbows up. They can support their head, that kind of gives them a little point of reference to bring their arms up and lay them on their hands. You're gonna still center, at the iliac crest, 2 inches above, if we're looking for the diaphragm. And the CR is still perpendicular to the IR, so we're still working at a 90-degree angle here. And it enters at the MCP, again, still 2 inches above that crest. This is what it looks like. You want no rotation. How can we see rotation on this? The hips might be skewed, very good. What else, Craig?
I mean, you'd still be able to see his spine twist a little bit. You'll
Right.
see the vertebral prominence in one direction or the other.
Right, so these start to look off, and these aren't quite lined up like they're supposed to. But Craig brought up a really good evaluation criteria. The crest should be on top of each other. They should be superimposed. This is near perfect. See the little gap there? This is near perfect. You're gonna get familiar with that superimposition term, because there's a lot of times where evaluation criteria is this superimposed on each other, right? As much of the remaining abdomen as possible when the diaphragm is included. So we don't have diaphragm on this, but they may be specifically looking for something that might be moving in the body. In this case, I don't know if you guys can see it. Can you guys see it in the back, Brittany's? I wish I could zoom in on this. There are stents. Can you guys see that?
Yeah.
Okay. There's stents right here. So they're looking for the placement of the stent. Hold on, just 2 seconds, Nicole. On this patient to make sure they're in good position. Okay? Yes.
They kind of look like wishbone, like a wishbone.
What looks like a wishbone? The stents? Well, so there's a couple different stents in here. These little markers are what they use when they're they're engaging the stent in the patient under X-ray in surgery. Okay? These are little markers that are intended to show up for us and
I'm
for the
glad
doctor.
that you're pointing it out, cause I can't even see those.
See little dots?
Yeah, I
Little
don't
dots.
see those.
So this is one big stent. And then there's a stent here and a stent here that probably does branch. So if you were to take the same patient and roll them on their back, right, it's gonna show that where it bifurcates.
That's why I saw wishbone.
Yeah.
I see what you're saying now.
Yes.
Yeah, now, okay.
Yeah.
All right. So little things like that. Try to pick up on some of them in your book or off the PowerPoints. Couple more slides and you guys can take a break. Again, this next is used for when the patient cannot stand and they're too ill to be on their side, right? If you've got an intubated patient, you may not be able to roll them to their side, okay? So you're gonna do it a little different. We're gonna go over a lateral abdomen, dorsal to cube, okay? You guys wanna go ahead and take that break before I dive into this?
Yes, please.
Okay,
Please, Kylie.
go ahead.